Uh, Mrs. RG, a 47-year-old lady hailing from Devanhalli, Bangalore, who has studied up till SSLC and is a farmer by occupation, presented to the surgery OPD with chief complaints of a lump in her right breast since 4 months and pain in her right breast since 10 days. History of presenting illness. The patient was apparently normal 4 months back when she noticed a lump in her right breast while she was bathing that was insidious in onset and gradually progressive from the size of a pea, approximately 1 into 1 centimeter, to the current size of about 8 into 8 centimeters. The patient also complained of pain in her right breast since 10 days, which was sudden in onset, gradually progressive, non-radiating, dragging type, which was on and off and persisted throughout the day, that was aggravated while she was working and relieved on rest. The patient also complains of weight loss of 3 kgs in the past 2 months. There is no history of swelling in the other breast, axilla, or anywhere else in the body. There is no history of nipple retraction, discharge, cracks, or ulceration. There is no history of chest pain, cough, or hemoptysis. No history of pain, abdomen, or jaundice. No history of backache or limb pain. No history of fever, headache, or loss of consciousness. No history of swelling in the arm, and no history of prior radiation exposure to the chest or any other part of the body. Past history, there have been no previous history of similar complaints in the past. The patient is not a known case of hypertension, type 2 diabetes, tuberculosis, or asthma. There is no previous history of hospitalization or surgery, and there is no history of any medications in the past. Family history, no history of any breast, ovarian, or colorectal cancer in any of the family members. There was history of throat cancer in the patient's elder sister 5 years ago, and she succumbed to it, and history of hypertension and type 2 diabetes in the patient's parents. Obstetrics and menstrual history, age of menarche, 13 years. The cycle were regular, 30-day cycles lasting for 4 to 5 days, and the patient used to change 3 to 4 pads per day. There were no clots or dysmenorrhea. She has been married for 27 years, and her obstetric score is para 2 living 2, and she's had 1 abortion. The first child was a male child born 27 years ago. It was a full-term vaginal delivery. He was breastfed for 1 year. The second child was a female born 25 years ago. She was also a full-term vaginal delivery and breastfed for 1 year. The patient attained menopause 2 years ago, and she was tuberculosis 25 years ago. Personal history, her diet is mixed, her appetite is normal, her sleep is adequate, and her bowel and bladder movements are regular. She doesn't have any addictive habits. Sir, I'll go to the beginning.
You summarize once?
Yes, sir. So, a 47-year-old female, Mrs. RG, came with complaints of lump in the right breast since 4 months and pain in the right breast since 10 days. The swelling was insidious in onset and gradually progressive, and she also complained of sudden onset pain since 10 days with a weight loss of 3 kgs. She's there's no history of swelling in any other part of the body, and she's a para 2.
Summary, just positive findings in favor of a diagnosis. That's a summary.
Yes, sir. Yes, sir. There's no history of any cancers in the family, breast cancers in the family members, and she's not and she's not on any medications or has any previous surgery, sir.
So what do you think at the end of the history? What it could be?
Sir, there are findings in the history that are suggestive of malignancy, sir, that the lump was rapidly it was rapidly growing, sir, from 1 into 1 centimeter to 8 into 8 centimeters, sir. She also has weight loss, sir, that could be suggestive of malignancy. And sir, I wanted to rule out if there was any family history, but nothing suggestive of breast, ovarian, or colorectal cancer in the family members, sir. And yes, sir, no history of nipple retraction or discharge.
Mainly, you're telling it's malignant because it was rapidly progressive in nature.
Yes,
right?
sir.
And her 3 months plus 7 centimeter. That's why you're thinking more. So anything other than that? What is in more favor of malignancy?
Sir, her age also, sir, and she's attained
Age and gender. Age and gender is
gender.
the high risk factor for malignancy. And
Yes.
any breast lump, unless and otherwise proved, it is a malignant breast lump. Okay, that's how it is.
Yes.
So okay, we will go in detail about the keeping it as a malignant breast lesion, each aspect. So first slide, please. So first slide, previous patient details. Yeah. So age is a risk factor, and gender is also a risk factor for breast cancer. Okay.
Yes.
What's the incidence of breast cancer in males?
Sir, less than 0.5%, sir.
Okay, up to 0.5 to 1%. Okay, 1% you can remember roughly. Okay,
Yes.
so has anything occupation has got to do with this breast cancer?
So there's no occupational exposure to radiation, sir, and no chemicals have been linked to development of breast cancer. So I don't think so, sir.
Okay, fine. Next slide, please. So, what are the causes for lump in the breast or in general?
Okay, so lump in the breast can be due to benign conditions as well as malignancy, sir. So in a premenopausal female, sir, fibroadenoma is a very common cause of lump in the breast, sir. There can also be a breast abscess in a lactating female, sir. In the postmenopausal age group, malignancies are the more suggestive diagnosis, sir. And sir, various duct pathologies can also lead to malignancy. So there is phyllodes tumor, fibroadenosis, sir, and sir, other conditions like breast abscess. That's what I could think of.
After trauma?
Yes,
the
sir. Trauma.
Could be simply remember it as five etiologies for anything, any disease. There could be 5 etiologies. One is congenital. Okay. Anything congenital breast swellings possible?
Sir, not that I'm aware of.
Next thing is could be traumatic. Anything traumatic possible?
Yes, sir. Hematomas can form.
Hematoma or traumatic fat necrosis.
Yes, sir. Traumatic fat necrosis.
Third thing is inflammatory. Third possibility is inflammatory. What are the inflammatory possibilities in breast which present as swelling?
The breast abscess.
Okay. So next is neoplastic. It could be benign swellings or malignant swellings. What are the possibilities?
Sir, benign swellings, fibroadenoma, fibroadenosis, sir. Then Andy, sir, aberration in normal development and involution. Sir, there's a in that there is lobular carcinoma in.
Okay, fine, that's okay. In broad, it's fifth etiology could be in anything. Is idiopathic. Idiopathic. Yes. So you have to you'll not miss out anything if you have a broad headings like this or template like this, then you'll not miss out, or you need not try to remember from wide range of conditions. Okay, so you'll have a template for each and everything. So next, what are the causes for pain in the breast? Sir,
so pain in the breast can be due to it could be cyclical mastalgia, sir, in menstruating females, which happens on a regular cyclical basis, and it aggravates on menstruation, sir. This is commonly seen in fibroadenosis, sir. Then pain can also be seen in inflammatory conditions like acute mastitis, and this is a throbbing type of pain, and is usually associated with pus. Sir, malignancies are generally painless, but in long-standing malignancies, there can be pain in the surrounding region, like the shoulders and the neck. And sir, other conditions like costochondritis, Tietze syndrome, and Mondor syndrome can also be pain in the breast region, sir.
Okay, good. So mainly, the breast pain is also called mastalgia, right?
Yes, sir.
Mastalgia. The causes for mastalgia are mainly the acute mastitis, in inflammation of this thing, or breast abscess. Thirdly, like you said, in the late stages of malignancy, because of the nerve infiltration or fungating or the necrosis of the skin, also they can have pain. Fourthly, musculoskeletal pain, underlying musculoskeletal pain, also you call costochondritis, one of them. Okay, that's called Tietz disease. Now the question is, the patient has both lump as well as pain. So now what are the possibilities? Separately lump we have discussed, separately pain we have discussed. Now the patient has
Sir, so lump and pain can be suggestive of certain benign conditions like fibroadenomas or fibroadenosis can have both a lump and pain. In fibroadenosis, it could be because of periductal mastitis, and even in malignant conditions, like I mentioned before, due to infiltration of the and the nerve involvement, sir, pain can be there.
the causes for lump with pain.
Yes, sir. So, if the lump and pain has been there since a long time, then it's suggestive of more benign conditions like fibroadenoma and fibroadenosis, sir. Whereas if there has been a short history of lump with pain, sir, it's more suggestive of malignant conditions of the breast, sir.
Why can't it be inflammatory?
Yes, sir. That will also have a short history, sir. Yes, sir.
Obviously, right. In this case, what's against inflammation?
Sir, there is no history of breastfeeding, sir. Breast abscess is common.
No. Need not be.
Sir,
In inflammatory, both the pain and swelling almost occur simultaneously, right? There won't be much gap of 3 months or 3 or 4 months like this. And inflammatory will not, very rarely it can be there for these 4 months or so. Okay.
Yes.
They will come to the attention, like patient will have severe pain and they will come to the doctor immediately. So there is a discrepancy between the onset of lump and the pain, which is more in suggestive of some malignancy, okay, not benign. So next slide, please.
Yes, sir. Sir.
So yeah, one more thing, one suggestion for you. This very 1 centimeter swelling and all may not be noticeable by the patient. Okay, it's very difficult to palpate 1 centimeter swelling and all. Patient may tell, but you should be very careful while choosing these words. Okay, be doubly sure about this. I don't say it's wrong. Maybe the breast size is small, then patient may appreciate. But even then, 1 centimeter lump may hardly noticed by the patients. And so far, patient has not gone to any doctor so far in 4 months.
No, sir.
If it's even till becomes 8 centimeter, patient was at home only.
Yes, sir. So she said that she came only after the pain started, and she ignored the lump till it started interfering in her work. So she came very late.
So what is this patient? Why did you mention this patient complains of weight loss of 3 kg in past 2 months?
Sir, it could be more suggestive of a malignant condition, and given that there is no loss of appetite also, it might be significant if it is a malignancy.
Why there is weight loss in case of malignancy?
Sir, cancer cachexia.
Cancer cachexia, weight loss will leads to cancer cachexia.
Okay.
Correct?
Yes, sir.
What happens? It's just a basic neoplasia lesson you have seen. They require more nutrition, right? So
yes, sir.
The cells take up more of the nutrition what you are taking, and the entire remaining body gets less nutrition. So this more of nutritional weight loss. Anemia, they will have patient will complain of they come with anemia in the blood picture. That's also mainly nutritional.
Yes, sir.
Okay. So more than you mentioned 3 kgs in 2 months. That's not. It could be intentional weight loss also. Correct. Patient may be doing some dieting also, though. That's why. So what you should be specifically mentioning is unintentional and significant weight loss, whether it is there or not.
Okay, sir.
That's more important. That's more suggestive of malignancy. What in other way? In which other condition of the breast can be weight loss can be there?
Sir, other condition. Sir, I cannot think of anything. Sir, tuberculosis of the breast.
Yeah, tuberculosis. Can this be tuberculosis? With,
yes.
That what's not there is fever. Fever is missing. Very mild, low grade fever could be there. So that's missing. Other than that, this can be tuberculosis as well. Okay.
Yes.
So next slide, please. So why have you asked these all those things? Can you please explain? No, it's just swelling in other breast, axilla, anywhere in the body.
Yes, sir. So I wanted to ask for swelling in other breast if it has metastasized to the contralateral breast, or if there is any lymph node enlargement that's causing swelling.
It may not be metastatic also. It could be primary also in the some of many times. What is the incidence of bilateral breast carcinoma?
Sir, bilateral breast carcinoma around 1.5 to 2.5%, sir.
Okay, so there could be primary also. So you have to check. It may be very small. One patient may not have noticed. So, but when you ask, patient may tell yes. On the other side also, it's there. Okay. So in swelling in elsewhere, you mean any lymph nodes or even metastatic lesions? They're also present with swellings elsewhere in the body.
Yes,
Why this
sir.
nipple retraction, discharge, and all?
Sir, if the swelling or the tumor is present just below the nipples, sir, it causes nipple retraction, and if it is invaded the ducts, then it can cause discharge, sir, which could either be serous or blood tinged discharge. And sir, cracks or ulceration to rule out, sir, to rule out Paget's disease of the nipples, sir, which is also one of the metastatic conditions, sir.
Not metastatic, it's a malignant condition.
Malignant conditions. Sorry.
Why is this chest pain, cough, hemoptysis and all?
Sir, to rule out lung involvement, sir, if the breast cancer is metastasized.
Where does the breast cancer usually metastasize to commonly and first?
Sir, to the spine, sir, through the Bateson's plexus.
So bone is the most commonly involved. Lumbar, and then comes the femur, then comes the thoracic vertebra. These are the most commonly involved. Then comes the lungs. So you can write it in the same order. There is no history of any bony pain or any pathological fractures and all. Then comes the lungs. So in the incident involvement wise only you have to write. That shows your application of the knowledge.
Okay, sir.
Correct?
Yes, sir.
Not randomly you have written. You know which one involves first. That show in the order if you write. You are understanding what I mean?
Yes, sir. I understood.
Yeah, that shows application of knowledge. Next, back pain, limb pain. That's for the C. Okay, agreed. The history of fever, headache, loss of consciousness. Why?
Sir, fever, I wanted to rule out tuberculosis, sir, as well as CNS involvement in late stages metastasis can happen to the brain.
So why is this swelling of arm?
Sir, swelling of arm could either be because of lymph node obstruction in cases of lymphatic obstruction in cases of neoplastic infiltration of the lymph node, sir, or if there was any previous history of mastectomy or something, then also there can be swelling of the arm due to lymphatic obstruction, sir.
What else? What else can cause swelling, limb swelling in a breast carcinoma?
So other causes.
Two causes. Okay, one is lymphedema. Lymphedema because of you have that lymph nodes. Okay, are all tumoricized, and there is no lymph cannot drain anywhere. So there is a collection of excessive lymph in the limb, causing lymphedema. Another possibility is a big lymph node is compressing over the axillary vein.
Okay.
Lymph node that is compressing the axillary, so venous flow is retarded. That also can cause obstruction. Sorry, what is it? Swelling of the upper limb. So how do you distinguish between the lymphedema and the venous obstruction? Between the lymphatic obstruction and venous obstruction, how do you distinguish?
Sir, the lymphatic obstruction is commonly defined as a brawny edema, sir. That happens.
Yeah, that's right. Brawny edema, correct. But see, in the lymphedema will be more prominent in the distally. It starts distally and then spreads proximally, and it's very slow.
Yes, sir.
Whereas venous obstruction is acute in onset and more common first in proximally, then it may involve the distal part. Yes. And there will be a very prominent bluish discoloration of the skin, the venous obstruction. That's how we distinguish between the lymphatic obstruction and the venous obstruction, right?
Yes, sir.
Prior radiation exposure, why?
Sir, history of radiation exposure to the chest is a known risk factor for breast cancer, sir.
Okay, so see, this thing has been like it's not in order. First, you have to confirm that what is the what is the breast etiology, whether it is a malignancy, benign or inflammatory. Once you confirm that it's a malignancy, then go for the metastatic features in that order, whatever I told you. Okay, then you can involve the what is the etiology for the malignancy. That order should come. It has been like jumbled up. First, yes, sir. Prove that. Rule out all other possibility and prove that it's malignancy. Once malignancy is proved, then the features of metastasis, then maybe at the end you may include also the reason for the malignancy. Is it clear?
Yes, sir. Understood.
Jumbled up. Next. Okay, past history. What kind of surgeries you are interested to know about?
Sir, if there was a previous history of a breast conservation surgery, sir.
Very good. Now this could be recurrence. Okay, what else? What other surgeries?
Sir, any any abscess drainage if she has had in the past, then it could also.
How it will cause malignancy now?
Um,
What other surgery? She has already underwent one surgeries. You have mentioned.
Sir, tubectomy.
Yeah, that's a surgery, right?
Yes, sir.
Tubectomy. So nearby there, any other surgeries you're interested now?
The salpingo-oophorectomy.
Oophorectomy, very good. Why oophorectomy?
Sir, oophorectomy is in patients with known BRCA mutation. It's a prophylactic surgery to.
That's one prophylactic. Always, other than that, see,
Sir,
that's the
estrogen.
estrogen production is from the ovaries. Okay,
Yes,
so unopposed estrogen is the positive for all this breast malignancy. So if there
yes.
is a oophorectomy has been done, there is a reduced risk, okay, of getting breast cancer. That's why. Okay, and any other breast surgeries in the past that you should be inquiring about. Okay, all this agreed with all these comorbidities. Next. Okay, family history, very important in the breast. Okay, so what are the types of in here breast cancers? You know, one is familial.
So sporadic and familial, sir.
Okay, so most of the cancers are sporadic. Up to 60-65% are the sporadic. Maybe 20-25% can be familial, and sometimes it could be in hereditary also. Okay, mother to daughter. Okay, next slide, please. Yeah, about BRCA1, BRCA2, you know in detail?
Yes, sir.
BRCA.
So, yes, sir. So BRCA1 mutation is associated.
What is BRCA? What is
So
BRCA?
breast cancer. Breast
Very
cancer.
good. Breast carcinoma. Okay. Which one is predisposing for male breast carcinoma?
Sir, BRCA2, sir.
Okay, very good. Okay. So again, this menstrual history is very important. Menstrual history, age of menarche. Why history of abortion is important?
Sir, the cause of abortion must be considered, sir. And if she was on any oral contraceptive pills that
No.
was associated.
What we are concerned about, see, by all this asking early menarche, late menopause, full-term normal vaginal delivery, by all these, what we are trying to elicit?
The estrogen exposure, estrogen exposure.
So, abortion means what?
Sir, the pregnancy couldn't continue till term.
Yes. So, what happens? Pregnancy instead of 9 months, it's only 4 months now. So, what happens next?
So there is more estrogen exposure.
Yes, immediate resumption of cycles after 4 or 5 months. So,
yes, sir.
4 cycles again instead of 9. Understood?
Yes,
okay? That's what we are concerned about there again. I attained menopause 2 years ago. This is again important. Menopause state, it's important in case of breast cancer. You can mention it even in the diagnosis also. Treatment varies according, no? The treatment varies according to if the patient is premenopausal or postmenopausal. Okay, yes, that's why it has to be considered. Next slide, please. Okay, diet. Why it's important?
Sir, high fatty containing diets lead to obesity, which is a known risk of breast cancer. Sir.
Then what else?
Sir, a diet rich in antioxidants is.
That is a protective factor.
Yes,
okay. Diet rich in phytoestrogens, antioxidants, they're all protective. Okay, only saturated fat is a risk factor. Yes. Appetite, okay, sleep is fine. What about the habits?
Sir, smoking consumption is known to be a risk factor. Smoking and
alcohol is also in the Bailey, it's clearly written. Okay, it's a high risk for breast carcinoma. Next slide.
Okay.
So now you understood. So this could be a sporadic case. There is no familial history or there is no known etiological agent or any risk factor seen in this case. So this could be mostly a sporadic breast carcinoma. The main feature which is characteristic here is rapidly progressive swelling. Okay, and initially it was painless. Now it is started painful since for last 10 days, which may be because of the mostly it is they complain of heaviness. More than the pain, they'll have heaviness or some dull aching pain because of the stretching of the skin or the viscera, or because of involvement of the skin. Sometimes fungation, necrosis, that can also lead to pain in the breast. Okay, so with this we'll proceed into the examination to confirm our diagnosis. Okay, please proceed.
Yes, sir. A middle-aged woman who is moderately built and nourished, conscious, cooperative, and well-oriented to time, place, and person. Her vitals are stable, blood pressure being 130/90 millimeters of Hg measured in right arm in supine position. Her pulse rate is 86 beat per minute, which is normal in rate, rhythm, volume, character, and there were no delays. The respiratory rate was 18 cycles per minute, and her temperature was 98.2 degree Fahrenheit. She had no pallor, icterus, clubbing cyanosis, or generalized lymphadenopathy and edema were noticed. There is axillary lymphadenopathy present.
Next slide. Yeah.
Okay, examination of the breasts. Consent of the patient was taken before the examination. The patient was examined in an adequately lit room with exposure up to the waist. She was examined in sitting, semi-recumbent, and recumbent position.
Why so many maneuvers?
Sir, so sitting in sitting we can see for the symmetry of the breast, sir, and when we in sitting position, when we make the patient raise her hands, we can notice for any nipple retraction, or we can see the lower quadrants of the breast better, sir. In semi-recumbent position, sir, we can in semi-recumbent and in bending down position, we can look for any more nipple retraction, sir, and
really? Okay. Sitting, the problem is lower quadrant you cannot see.
Yes, sir.
Sitting, especially when the pendulous breast, they fall down, and lower quadrant may not be visualized in the sitting. So you make the patient semi-recumbent, wherein you can see the lower quadrant as well. The problem, again, recumbent is not preferred way in breast examination, because when they're sleeping or recumbent, breast falls away. Breast falls away. So even then the examination is difficult. So preferred way is semi-recumbent. First, initial sitting, definitely to look for the symmetry or any nipple deviation. Second is semi-recumbent position. Clear?
Yes, sir.
Okay, next.
Sir, on inspection, inspection of the breast position, the right breast is at a lower level than the left breast. Shape and size, the right breast appears larger than the left breast. No puckering or dimpling is seen. Swelling, a diffuse lump is seen on the right breast, predominantly in the upper outer quadrant, measuring about 10 into 10 centimeters with a smooth surface. The skin over the lump appearing normal.
You think the involved breast is lower than the normal one?
Yes, sir.
Okay. What is this puckering and dimpling?
Sir, puckering and dimplings are dimpling is seen if the if there is involvement of the suspensory ligament of the Cooper, so there'll be dimpling, that is pulling of the skin at the site of the ligament if there is involvement of the ligament due to carcinoma, sir.
Very good. What's puckering?
Sir, puckering is any region other than the areola, sir, if it's involved, and I'm not sure,
see, the single suspensory ligament of Cooper is dimpling.
Yes, sir.
Small this thing, whereas a large area of what is this ligament of Cooper, big tissue, a chunk of tissue or skin is retracted inside, then it's called puckering. Some refer if the involvement of the pectoralis fascia is there, then it's called puckering, they say, but mostly it is involvement of large area of what is this ligament of Cooper. It's called, okay, a big dimple is puckering. Understood?
Yes, sir.
Okay. Next, what other skin changes you can see in on inspection?
So there can be orange peel appearance or body orange, which is seen due to the involvement of the subdermal lymphatics or in malignancies. And sir, other skin changes that are not particularly
Weakness of skin involvement in a TNM staging of carcinoma breast.
Sir, if there is skin involvement, it is T4B, sir.
Agreed. What are the features?
Features.
Is a dimpling
Sir,
is a skin involvement?
no, sir. Dimpling and
Puckering is a skin involvement?
no, sir.
So what are the skin involvement features then?
Sir, if there is involvement of
The TNS staging, you should know that. You should clearly mention. One
Yes.
is Podaraj appearance.
Yes,
Second
sir.
is
Sir, if there is fungation or ulceration.
ulceration and fungation. Third is
Sir. Sir, if there is if satellite nodules and if there is an ulcer, sir.
Okay, cancer. So three. Okay, three things. First is Podaraj appearance. Second is ulceration fungation. Third is satellite nodules.
Yes.
Where else you see satellite nodules, Shambhavi? Which other conditions?
Satellite nodules. Sir, I'm not aware.
Malignant melanoma, have you heard?
Yes, sir.
Okay. Okay. So swelling is diffuse lump, 10 into 10 cm with smooth surface, skin over the lump appearing normal. Okay, fine. Next. Dilated veins present. What are the causes of dilated veins over the breast?
Sir, dilated veins can be seen in malignancy, sir. It can also be seen in Phyllodes tumor, sir.
So which are the common malignancies where you can see the dilated veins?
Sir, invasive ductal carcinoma.
Not really, not like that. Any vascular tumors,
Okay.
very rich in vascular tumors like sarcomas, angiosarcomas, okay. And then like you told, phylloids, very big tumors or big abscess also, big abscess because of compression over the veins, they can be get dilated. Okay. So sarcomas, very large abscess or the tumors, phylloids tumor. Okay, and in a particular carcinoma, there is a particular carcinoma of breast called medullary carcinoma, which is very vascular. Medullary carcinoma also, these veins could be dilated. Okay, so again, things have been messed up. Is there? You're told skin is normal. Then again, you need not mention there is no Podaraj, no nodules, no. You need not mention. You already mentioned that skin is normal. Skin, okay. Nipple, both nipples present and symmetrical, normal size, no flattening. Okay, fine. Next. Mainly, you are looking for nipple retraction. That's again the one of the characteristic features of malignancy.
Yes. So it appears normal, sir. It's brown in color and the diameter is 3 centimeters.
Arm on rising above head, no changes the shape and of the breast. Okay, fine. So actually, you should be examining the lump in 4 positions. What are the 4 positions? Arms by the side.
Yes, sir. Arms on the
raised above your head. Okay, especially if any small discrepancies are there between the nipple and this thing, you cannot make out in the arms by the side. So when the pectoralis is contracted, that time you can appreciate better. Third is
sir, arms on the hips
arms against the hip. Okay, so that time again pectoralis is contracted, so you can appreciate the lump better. Fourth is
pushing against the wall.
Bending forward. No, bending forward to know either any chest wall involvement is there or not. Okay, if the breast falls forward very freely, then there is no chest wall involvement. Okay.
Yes, sir.
Okay. Next.
Sir, palpation. The left breast.
I like this point. Always first you should palpate the normal breast, then come for the abnormal one. Okay. Good.
There is no, on the right side, there is no local rise in temperature, but tenderness is present, sir. A single lump of size 8 into 8 centimeters was felt near the areola, which was globular in shape. It had a nodular surface and it had a well-defined margin and it was firm in consistency. The lump was not fixed to the overlying skin. The mobility of the lump
How do you say that?
Sir, which point, sir?
No, how do you say lump is not fixed to overlying skin?
Sir, fixity of the skin can be tested when we move the tumor up and down, sir. There'll be a dimpling or tethering that can be seen. So that was not seen here.
No, don't be. It's not that difficult. The skin can be overlying skin, pinchable.
Yes, sir.
Okay, the skin can be pinched. Like this, see, overlying skin freely, it can be pinchable. Then it means that skin is not involved. Okay. Yes, and how do you say this is not fibroadenoma?
So that is the mouse tumor, sir. If we hold
Okay.
the breast and we
The mobility there is independent of the breast tissue.
yes, sir.
Okay, independent of the breast tissue, you can move the lump freely without moving the breast tissue. Whereas breast carcinoma, you cannot. It's arising from the breast tissue itself. So you cannot move the tumor independent of the breast tissue.
Yes, sir.
Understood?
Yes,
so
sir.
next is you can't directly write attached to chest wall. Have you checked for the involvement of the pectoralis muscle? How do you check for the involvement of the pectoralis muscle, pectoralis major?
So we asked the patient to place her hand on her hip, and
Mhm.
first she has to lightly place it on her head, on her chest, and we move the tumor in the direction of the pectoralis major, that is diagonally and perpendicular. So in both, if we are able to move it, then it is mobile. Then we ask her to tightly place her hands on her hip and try to move it again, sir. We will see that in the direction of the pectoralis major, there will be less mobility, but perpendicular to it, it is slightly mobile. So in that case, we can tell that it is fixed to the pectoralis majors.
Okay. So which are the nearby muscles? Like how do you check for fixity to serratus anterior, latissimus dorsi?
So serratus anterior involvement is there if the tumor is present in the lower and outer quadrant, sir. So in that case, we ask her to press the same side hand against the wall, and then we try to elicit mobility. So in that case, the serratus anterior will become taut.
Latissimus dorsi?
So the latissimus dorsi will not directly be involved, sir, because
Can be. It can be.
uh,
How do you check?
sir, we ask them
What is action of the latissimus dorsi?
to touch the opposite side shoulder.
Not really. Okay. Flex the elbow and extend the arm. When you extend the arm against the resistance, then the latissimus dorsi becomes a very prominent. Okay. Then you can try to move the lump over there. If it is mobile, it's free from the tumor invasion. If not, it's okay. Understood.
Yes.
So what do you mean by chest wall here?
Sir, chest wall is the pectoralis major muscle, sir. It's the serratus anterior muscle and the ribs, sir.
That's a common mistake all the students do. Okay. So pectoralis major is not a part of chest wall. Agreed?
Yes,
So
sir.
chest wall means ribs, intercostal muscles, and the serratus anterior only, not the
Okay.
pectoralis or latissimus dorsi.
Okay, sir.
Clear?
Yes,
Chest
sir.
wall involvement refers to what's the tumor staging if it's a chest wall involvement is there?
Sir, T4B, T4C.
Are you sure? What's T4A?
T4A is chest wall involvement, sir.
What's T4B?
The skin involvement.
T4C is
T4C is both involved.
A and B, both A and B.
Yes, sir.
Okay, so chest wall. So the question will be tricky. MCQ it will be asked. Okay, the tumor involves the pectoralis major muscle. Okay, and this. What is staging? They'll ask you. Then you'll write it as T4A, which is wrong.
Yes, sir.
Pectoralis major is not a part of chest wall. Clear? That's what the need to be clear.
Yes, sir.
Next.
Sir, examination of lymph nodes, axillary lymph nodes, pectoral, brachial, subscapular, central, and apical group of lymph nodes were non-palpable, and cervical group of lymph nodes were also non-palpable.
You told axillary lymph node present in the beginning.
Yes, sir. But then when we did it properly, like we didn't get the findings as was mentioned in DAS, so it was very confusing.
Then you can mention as not there only. Or not
Yes.
palpable only. There it's contradictory in the you have written this paper sheet after examining everything, right?
Yes,
so you
sir.
can't put one in one place it's present, one place is absent. You are contradicting your own statements.
Yes, sir.
Clear? So
Yes,
if it's present, palpable. If it's not palpable, present, like not palpable. Okay.
Yes, sir.
Now, okay. Since you suppose it, now there is pectoral lymph nodes were present.
Yes, sir.
Supposedly in your patient, there was a 2 into 2 centimeter pectoral lymph node were present. You say pectoral lymph nodes present. And I say this is axillary tail of Spence.
Yes, sir.
How do you substantiate yourself, or how do you differentiate between two?
Sir, so axillary lymph node is the continuation of the breast tissue towards the axilla, sir. So its consistency when felt will be similar to the breast tissue, and we have
Which
already
one?
sir,
Which one?
the axillary tail of Spencer.
Okay, very good.
And we have already examined the normal breast, sir. So we have an idea of what the consistency of the normal breast is. So the axillary tail of Spence will have a similar consistency, whereas a lymph node will have a firm
Difficult.
or
Both are firm. Both are firm in consistency. Difficult to distinguish. If it's hard, I agreed. If the lump was hard, and I agreed. Here, see, simple. Axillary tail is a part of breast tissue, right? It's not separate entity. It's a part of the breast tissue. So when you move the breast tissue with that, even the axillary tail of Spence also moves.
Yes, sir.
Whereas lymph node doesn't move when you move the breast tissue. Clear?
Yes, sir.
Okay. So how to examine the axillary lymph nodes, you know, which are the groups and how to examine them? Very important.
Yes,
They may ask you to demonstrate in the examination.
Yes.
Why have you included cervical lymph nodes? If you included supraclavicular and all, I agree. Why you, whether the breast cancer spreads to cervical lymph nodes? Anyway?
Sir, so in DAS, supraclavicular is given under the heading of cervical. So I also
Supraclavicular. Supraclavicular is a part of axillary, yes.
is given under cervical.
Okay, that's why I included cervical.
Yes, sir. I mean, we examined supraclavicular only, but the heading was given like that, so I wrote it. I'll change it.
Okay, next.
So systemic examination, CVS, RS.
Again, one more system should have been included. What is that? Musculoskeletal system.
Musculoskeletal.
The first one, okay. Musculoskeletal system should have been included. Then comes the respiratory system. Okay. Then comes the CVS or then CNS, whatever.
Yes.
Okay, clear?
Yes,
that should be in order. Musculoskeletal, you will check for particularly any tenderness, bony tenderness is there, any pathological fractures are there.
Yes, sir.
Next.
Sir, investigation.
Okay. So now, after the can you please again summarize at the end of the examination? You have to tell the summary of both from all the positive findings from the history as well as examination. That should be routine because the examiner may not be listening to you through the entire presentation. When you tell summary, suddenly they'll be alert. So you should be summarizing your case at the end.
Yes, sir. A 47-year-old female presented with complaints of lump in the breast since 4 months and pain since 10 days, sir. She is attained menopause 2 years ago, sir. There is no family history of breast cancer in any of her relatives.
That is not the favor of your diagnosis or any weights. There's no need to include because whether does family history helping here? If it is positive, okay, that will help you. If it's not there, then it's no need to include. Summary means only positive findings. Okay, what you should have included is the swelling which is rapidly progressive in the 3 months. Okay. Okay, present on examination. Swelling of
10 into 10 centimeter.
No, usually it's hard in consistency. I don't know how you got the form in consistency. Maybe okay, form in consistency with the no axillary lymph nodes palpable.
Yes, sir.
So most likely, it's a case of breast lump, which is malignant in nature.
Yes, sir.
Okay, that's how. So next is clinical staging. You should include 3 things in your diagnosis. One is breast cancer. Okay, carcinoma of the breast is the first thing. That's the malignancy. Second thing is it's a pre-menopausal or post-menopausal status. That's important for the management. So you have to include that.
Yes, sir.
Okay. Third thing is the staging. Staging is enough. Then you need not tell that no evidence of any local or systemic complication. What is a systemic complication? T3N0M0 means you understood it's not metastatic. Then you separately need not mention that no evidence of any complications and all.
Yes, sir.
So first thing is, this is a case of single firm lump. No, that's not the diagnosis. Diagnosis is a clear cut. It's a carcinoma of the breast. Okay. In a post-menopausal lady, clinical staging C, T3N0M0. That should be your final diagnosis. In a sense, a provisional diagnosis, I meant.
Yes, sir.
Next, examiner will ask you, how do you proceed?
Yes, sir. So we will proceed with the investigations
And
followed
to
by the
confirm the
treatment
diagnosis.
to
That should
confirm
be
the
your
diagnosis.
answer.
Yes.
I want to confirm my diagnosis. So I want to do some certain investigations like
Sir, so radiology will be the first step.
first, how do you proceed? Means the first word you should be uttering is, sir, I want to do triple assessment. In that
Triple
breast,
assessment.
any breast case, that word should be, you should be answering.
Yes, sir.
Triple assessment, that word should come.
Yes,
So as
sir.
soon as the exam will ask you, how do you proceed? Sir, I already done the clinical history taking and examination. Now I want to do radiological and pathological investigations. First, I want to do radiological. Okay, like since she is more than 45 years old, I want to do mammography of the both the breasts with ultrasonography of the both axilla.
Yes, sir.
Understood?
Yes,
And
sir.
then I want to do pathological investigations like
Sir, FMAC and
on
core cut
clinical biopsy. That
Yes.
completes the triple assessment. The sensitivity and specificity of which is 99.9%. You
Yes,
becoming
sir.
right.
Yes, sir.
Understood? All other test and all comes later. First, to confirm the diagnosis. Okay. Second, to look for any metastasis is there. Then third, investigation related to your general fitness, everything.
Yes, sir.
Okay. So now, what are the features of malignancy in mammography?
Yes, sir. So on mammography, sir, the malignant tumor has an irregular shape, sir. There's presence of microcalcification, sir, and there is also presence of multifocality, sir. Like
Not be always. It could be there. If it is there, you can make out. Then mine is architectural distortion.
Yes, sir.
Architecture would be lost. Okay. And then there will be heterogeneously enhancing when one lump or some mass lesion will be there with irregular borders and with microcalcification, speculations, these star-shaped speculations around it. Okay. All these are features of malignancy on mammography. What are the views in mammography? What is mammography, by the way? What is
X-ray of the
X-ray? What kind of X-ray? Not normal X-ray, usual X-ray. What we
xenoradiography.
No, it is a low voltage, high amperage, high current, but low voltage. Nearly 300 milliamperage current and 40 kilowatts of voltage. Low voltage, high amperage X-rays are called mammography, where very low dose radiation like 0.1 centigrade.
Yes, sir.
10 times less than the normal X-ray radiation is used. That's mammography. Which are the views in mammography?
Sir, there are two views, sir. One is
caudal.
Yes, sir.
And mediolateral oblique.
Yes, sir.
Medial to lateral and oblique like this. Medial, and one is craniocaudal, mediolateral oblique. These are the two commonly utilized views.
Yes, sir.
The drawback of this mammography may not involve the axillas. We cannot receive the axillary lymphadenopathy in this. For that, we have to separately get a
ultrasound of the axilla.
Okay, that's okay. So why do we use mammography in elderly females? Why not in young females?
So in young females, the breasts are dense because of large amount of ductular structure, sir. So it's a low sensitivity in young patients, sir. So ultrasound is preferred.
Okay. So why this PET scan? But directly in all the patients you get PET scan?
No, sir, it is only to look for metastasis, regions of metastasis. But if the patient is not affordable for PET scan, then we can do USG abdomen, chest X-ray, spine X-ray.
What is USG abdomen for liver mets? All these are mainly done in locally advanced breast cancers, not in this early breast cancers and all. Okay, only in locally advanced this thing. First you get LFT done, then okay, then CT of thorax and abdomen,
Yes,
then
sir.
the bone scan, all the
Yes.
long bones you should get done. Okay, before that you can get a alkaline phosphatase, serum alkaline phosphatase. If it's included, that's suggestive of bone secondaries.
Yes, sir.
Okay, that's a blood marker. Okay, you heard about radioisotope scan?
Yes, sir. I know one of its applications, a sentinel lymph node biopsy, is one of the applications of radioisotope scan, but more than this, I haven't heard, sir.
Okay, next
Sir.
slide. Okay, that's with all the investigation. Next, you want to okay, about FNAC versus core needle. Which one you prefer?
Sir, the core needle biopsy, true cut biopsy is the investigation. Sir, it can differentiate between in situ versus invasive carcinoma, sir, and it has less false positive, and it's also useful in determining the receptor status, sir, ER, PR, and HER2 status.
And also the grade of the tumor.
Yes, sir.
Whether it's well differentiated or poorly differentiated, all those things you can make out with the core needle, but not with the FNAC. FNAC only cells are there. In cells, you can just tell whether it's any ATPI is there, any nuclear pleomorphism is there. You can definitely tell it's a malignancy or not with the FNAC. But high false negatives are more if you're not taken from the right place. But in the core needle, you're taking a chunk of tissue. So all these tissue receptors like estrogen receptors, progesterone receptors are present over the tissue level. So that can be missed in FNAC. That's it. So core needle biopsy will tell you about the receptor status, also about the grade of the tumor, also whether it has got any lymphovascular invasion.
Yes, sir.
Okay. All these things, ideas will get with core needle biopsy, but not with FNAC. So nowadays, the gold standard is core needle biopsy. Even with core needle, you get inconclusive. FNAC twice you did, it's inconclusive. Core needle also inconclusive. What you will do next? Any other types of biopsies, you know?
The excisional biopsy will prefer.
Okay, if it's very small, less than 4 centimeter, you can go for directly excisional biopsy. What else? What other types?
So punch biopsies.
No punch biopsy.
I'm not sure, sir.
Incisional biopsy. Incisional biopsy. You can make an incision and take out a small chunk of the tissue, but make sure that your incision should be along the line of future surgery. It should be included in the future. Like that, you should mark your incision. Second thing, have you heard about frozen section?
Yes, sir. Frozen section.
What is that?
Sir, it is done intraoperatively, and we get the result during the surgery to determine future course of action.
Okay, that's also another type. Okay, if there is a skin involvement and all there already, then you can go for wedge biopsy. It's called wedge biopsy. Some amount of the normal skin as well as some amount of the ulcerated skin that you can send for the biopsy that can confirm the malignancy. Okay, these are the various types of biopsies. And after the investigation, it comes to be in this, for example, T3N0M0. Clinically, it comes as invasive ductal carcinoma with no signs of any metastasis. Okay, and there is lymph node. T3N1. Okay, let it be T3N1. Okay, after investigation, it comes clinically T3N0 agreed, but there were some small lymph nodes were there. T3N1M0. Okay, with the ER, PR, and HER2 positive.
Yes, sir.
How do you manage this case?
So, sir, the approach of management in this case can be surgery, chemotherapy, radiotherapy, or hormonal, sir. So, surgery, there are two types, sir, breast conservation surgery as well as mastectomy, sir. So, if the patient opts for breast conservation surgery, then she has to undergo a round of radiotherapy to avoid local recurrence. And in mastectomy, it is radical.
Before that, if you opt for the breast conservative surgery, before the surgery, what you need to be giving?
Sir, before the surgery,
neoadjuvant chemotherapy.
Neoadjuvant chemotherapy, sir.
Because it's a large tumor, no? You cannot do with such a large tumor. You cannot conserve anything. Hardly 10 centimeter tumor, and almost entire breast is involved now. Okay, so you cannot preserve anything. So first, you should try with the neoadjuvant chemotherapy. If the tumor shrinks so much so that there is a you can leave behind a significant amount of breast tissue. Only then go with breast conservative surgery, but not for all these such big tumors. You can't do breast conservative surgery. Okay.
Yes.
Then
So there's mastectomy and modified radical and modified radical mastectomy, sir. So in this, there is removal of the breast and the nipple areola complex along with the 3 levels of lymph nodes. And depending on MRM or RM, even the pectoralis major and minor may be removed, sir. Then chemotherapy is another modality of treatment. Chemotherapy is only given in patients who can tolerate it. So in
T3, see, in this, I'm telling you a specific case scenario. What you're doing for that, you tell. I'm telling you, no, it's T3, N1, M0.
yes, sir. So
T3 means what?
So T3 is more than 5 centimeters.
Okay, so it's 5. Okay. Next, what is N1?
Sir, N1.
T4B, T4A. It's not T4A. T4A means what is that? Chest wall is involvement. Okay. T4B is skin involvement. So T3 is just a tumor is big enough. There is no any muscle invasion. Even the pectoralis muscle also not involved. So you need not do radical mastectomy.
Yes,
correct?
Sir.
Only
yes,
modified radical is more than enough, sufficient. You can preserve the pectoralis muscles. Okay,
yes,
you
sir.
want to modified radical mastectomy in this case.
Yes, sir.
Before that, you can give neoadjuvant chemotherapy to shrink the size of the tumor.
Yes, sir.
Okay. After that, modified radical mastectomy. There are 3 types,
Sir, Ocean Cross, Pate and Scanlon, sir.
Pate is which one we do now? Which is the preferred one?
Sir, I'm not.
King clause. King clause. Because there we preserve the pectoralis minor. Okay, by just we retract the in Pates, we divide the muscles, okay, from the origin, whereas in the scanlons, we just split the muscle. In the King clause, we just retract the muscle and remove level 1 and level 2 only, not the level 3. Level 3 lymph nodes are usually not removed. Only level 1 and 2 are removed. Why? To prevent future lymphedema.
Okay.
If you remove all the lymph nodes, okay, so where will the lymphatics will drain to? There won't be anything, any nodes left to drain lymph.
Yes.
So we leave behind the level 3 so that lymph can flow easily and there will be no lymphedema formation. Clear?
Yes,
Is
sir.
it clear?
Yes, sir.
Okay. So after the mastectomy, we remove clear the level 1 and level 2 lymph nodes also. Then we close. So next, what do you do further after surgery?
Sir, chemotherapy is
continued. And along with that, what else?
Sir, since it's a hormonal ER positive, PR positive, we can also give hormonal therapy, sir. That is selective estrogen receptor modulators, a tamoxifen. And since she's a postmenopausal lady, sir, we prefer aromatase inhibitors. That is letrozole, anastrozole, exemestane can be given. If HER2/neu was positive, then we have to supplement it with trastuzumab, sir. Herceptin,
not trastuzumab. Wonderful. What is the role of radiotherapy? What are the indications for radiotherapy?
Sir, if the patient cannot tolerate chemotherapy, I'm not sure, sir.
There are specific indications for radiotherapy.
Yes, sir. If there is no prior chest wall irradiation.
No. If the surgical margins are positive, what are the margins positive, or any lymph nodes are comes as positive, okay, or internal mammary lymph nodes are present.
Yes, sir.
Okay? Or if the pectoralis muscle invasion is there, or if you after doing breast conservative surgery, you only told no. For breast conservative surgery to be done, patient should be compliant for radiotherapy, willing for radiotherapy. So that's another indication for radiotherapy. Okay, so these are the 4-5 indications for radiotherapy.
Yes, sir.
Okay, so what is the chemotherapy regimen or the drugs you want to give in this patient?
Sir, CAF regimen or CMF regimen, sir.
What is
that is cyclophosphamide. Then there is adriamycin and 5-fluorouracil, sir. Or there is cyclophosphamide, methotrexate, and 5-fluorouracil, sir.
Okay, fine. Now, CMF. So after a patient is on adjuvant chemotherapy, after 2 months, patient comes with hematuria.
Sir, this is a side effect of cyclophosphamide, sir, hemorrhagic cystitis. And to prevent it, we give the patient mesna, sir, so that she doesn't have hematuria.
Very good. Wonderful. See, this is the application. Understood how the questions will be framed in your next exam or in the entrance exams. Okay. See, if you, there's an indirect way of like application of your knowledge. So next, patient present with so many secondary bacterial infections. After when a patient is on chemotherapy.
Yes,
What
sir.
may be the reason?
Sir, methotrexate, it causes anemia and also leukopenia, sir. So that could be the cause of infections.
Cyclophosphamide also causes bone marrow suppressions, leukopenia, all those things. Okay. So methotrexate is avoided. So you told CAF regimen.
Yes, sir.
After the 2 months, patient will come with heart failure features with breathlessness and all.
Sir, adriamycin, bleomycin, all of them are cardiotoxic. That
So you have to get a baseline echo done. Before
can
starting the chemotherapy, baseline echo should test for the cardiac function. Clear? So these are the side effects you should know. Common side effects, what all it can cause, how to overcome that, you should know. Clear?
Yes, sir.
So what are the other ways of, other than trastuzumab, what are other hormonal therapies you know?
Sir, newer drugs are there, sir. Monoclonal antibodies, sir.
Pertuzumab.
Palbociclib, sir. Palbociclib. And sir, trastuzumab, one more I know.
Trastuzumab you told.
Sir, sir,
Other hormonal therapies, you know, other hormonal therapies.
Sir, Claudin inhibitors, sir. They're the Claudin positive breast cancer. So Claudin inhibitors are there.
Next.
Sir, if only those many I could recall, sir.
See, mainly you have to want to inhibit the ovary. Or next, postmenopausal stage, mainly adrenals. The ovary, like estrogen production is from the adrenals. So you have to inhibit the adrenals. So what are the ways to inhibit the adrenals?
Sir, steroids, sir.
Pharmacology you learned.
Yes, sir.
Chemical adrenalectomy and all. What are the drugs which used for chemical adrenalectomy? Or medical adrenalectomy? One of the hormonal treatment is oophorectomy.
Oophorectomy, yes.
It's a type of hormonal therapy only, no? You are suppressing the hormone production in the premenopausal. Okay, postmenopausal, mainly adrenals. Adrenalectomy you can do. Oh, chemical adrenalectomy can be done by which are the drugs?
Chemical adrenalectomy. I don't remember. Sorry.
Aminoglutamide, you know?
No, sir.
Like other drugs like reversible non-steroidal drugs like taxanes you can use?
Yes, sir. Paclitaxel. Yes, sir.
Not taxanes actually. This aromatase inhibitors. Sorry, not taxanes. Taxanes mainly chemotherapy. Here you can use letrozole, anastrozole, etc.
Yes, sir. I mentioned that. Yes, sir.
So these are the other ways of hormonal therapies. Clear?
Yes, sir.
Chemotherapy you are told. Okay. What is if it is already metastatic? How do you manage this case? It's already M1, T3, N1, M1. How do you manage? For example, now you have lymph nodes in the opposite, in the left axilla also. What is that?
Sir, left axilla.
With the lymph nodes in the left axilla.
Sir, N2.
Not N2. It's considered distance metastasis only. It's M1.
Okay. Yes, sir. M1.
Okay. Yeah. Okay. How do you manage that?
So it's mainly palliative, sir. If there is already M1 metastasis, we can give chemotherapy. We can continue chemotherapy if the patient was receiving it. Radiotherapy is preferred for bony metastasis, sir. And if there was a hormonal component, then we can also continue the hormonal therapy, sir.
What are the complications of mastectomy?
Sir, seroma is the most common
Very
complication.
wonderful.
Then it's prevented by an drainage tube, sir. Chest
Drain you can keep, okay. Vacuum suction drain, then
Sir, bleeding and lymphadenopathy is all. I mean, not lymphadenopathy.
lymphedema. So later,
Lymphedema. Yes, sir. Lymphedema.
very late stage. Soon after that, flap necrosis can occur. See, any complication when you answer, any surgical complication, you should tell intraoperative and immediate post-operative, late post-operative. Intraoperative, what all can happen?
The bleeding can happen.
Bleeding, okay. Next.
Nerve injuries can happen, sir.
Very good. What are the nerves?
Sir, long thoracic nerve of Bell's, serratus anterior is there only. Then intercostal brachial nerve, sir. The same
that
nerve.
You can sacrifice, no problem. That is the one nerve which you can sacrifice. Intercostal, nothing will happen. Only sensory nerve it is. Then which is other nerve? Thoracic or dorsal nerve, which supplies?
Latissimus dorsi.
Okay, so these two nerves to be preserved. And what are other structures to be preserved? Axillary vein and?
Axillary vein and pectoralis major.
That's anyway preserved. In the axilla, which are other structures?
Lateral pectoral nerves, sir, which supply the pectoral.
Yeah, very good. Very important. Both the pectoral nerves, medial and lateral pectoral nerves has to be preserved. You have beautifully preserved the muscle, but you have injured or damaged the nerve, then no use. The muscles will go into atrophy. Okay, so both the the lateral pectoral nerve is present medially and medial pectoral nerve is present laterally. Okay, they are according to the parts, they'll mention like that, lateral and medial, but they present vice versa. Understood? Keep this in mind.
Yes, sir.
Okay, this is about the axillary clearance. Everything you should know. What is the extent of axillary clearance? Like what are the boundaries of axillary clearance? All those things you should know. And what are other complications? Immediate nerve injuries, bleeding, etc. And immediate post-operative seroma formation. Okay, seroma formation, and then there could be flap necrosis. If your skin flaps are very thin, lost its clarity, then it can cause necrosis of the flaps. Clear? Then late complications.
Sir, late complication can be Stewart-Travis syndrome.
Lymphedema first, lymphedema. Then it can be long-standing lymphedema can result in lymphangiosarcoma. That is Stewart-Travis syndrome. Okay. And then it can it can also lead to recurrence. One of the later complications is recurrence. If you're not adequately remove the tumor, it can lead to recurrence as well. So these are all the late complications. Okay, if the nerves are injured, what are the consequences? You should know.
Yes, sir.
Okay, so next another aspect of breast cancer is breast reconstruction. After the surgery, there is a scope for breast reconstruction, especially young lady. She's a 47-year young lady. You should give her option of breast reconstruction. So what are the modalities, common modalities used for breast reconstructions?
Implants are present. The silicone gel implants can be used under the pectoralis major, sir. Flaps can be created, sir, from latissimus dorsi and the transversus abdominis muscle flap, sir.
Rectus abdominis.
Yes, sir.
Tram flap. Transverse rectus abdominis myocutaneous flap. Or latissimus dorsi myocutaneous flaps. These are the most commonly used. Okay, then
the deep DIEP flap, sir, deep inferior epigastric perforator flap, sir. And prostheses are always an option, the external breast